So how many of you are completely new to resilient healthcare? We've got a few, that's great, because I'm going to start right at the beginning. Okay, so the first slide I just want to show you is this one, because it's quite a good way of conceptualizing it. So when you think about healthcare, we often concentrate on the 10% of things that go wrong and that 10% of adverse events. But when you think about it, 90% of things go right. And resilient healthcare, or safety 1 and safety 2, is sort of flipping things on their head. So rather than exploring that 10% of things go wrong, we're going to explore the 90% of things that go right and try and understand from that how to make more things go right. So safety 1 is the traditional view of safety, where you're trying to make the adverse outcomes as low as possible, and trying to stop things from going wrong. But you're very much concentrating on what's going wrong. So when you think about healthcare workers coming to work and doing their job, they're going to be making little adjustments day to day in everything they do to make sure that things go right. And when they make that adjustment, they're going to get an outcome. And that either might be a right outcome, or it might be a wrong outcome, or an unexpected outcome. But the thing about that is that it's only in hindsight that we know whether it's a right or a wrong outcome, because no one goes in there intending to do a wrong outcome. So it's the same action, but it could end up right or wrong. So what we want to try and understand is when people are going there in healthcare making those adjustments, what is it about it that leads to good outcomes as opposed to bad outcomes? So we're trying to make sure as many things as possible go right. So when we talk about safety 1 and safety 2, we have a different way of approaching it and a different way of learning. So the safety 1 way of learning is learning from these things that go wrong. So we're looking at safety incidents, we're looking at unsafe situations, and you've got to wait till something goes wrong before you can learn from it. So you're waiting for the accident before the learning can start. Whereas safety 2, we're learning based on everyday work. So we can learn every day, we can learn proactively. We don't have to wait for something to go wrong before we can start to learn. So it's really just a change of approach, where instead of focusing on that really tiny number of things that go wrong, we're focusing on that big number of things that go right. That means that we've got a lot more data to help us, understand what's happening. And we're also more likely to get accurate data, because people are much happier to report what they do when things go right than they are when things go wrong. Often you don't get accurate reports of what happened when things go wrong. So safety 1 and safety 2 are sort of, we look at it in terms of resilient systems. So resilience is the ability of an organisation. I mean, there's a definition up there, which is our standard definition. But essentially what we're looking for is we're trying to continue to do the work that we do despite the challenges or events that try and upset us or stop us from doing that work. And to be resilient, we sort of consider organisations need these 4 different abilities. So they need to be able to respond to things that happen. They need to be able to anticipate what's going to happen. They need to be able to monitor so that they know when it's going to happen before it actually hits them, and they can be proactive. And they need to be able to learn from past events. So we've got a lot of books. So, and a lot of what I'm talking about is in these resilient healthcare books. So there's been books produced since 2013. Most of the books are about case studies. So things that have happened in healthcare and how different people have dealt with it in a way that's resilient. So I just want to go through a couple of terms that we use, because a lot of people can get confused about the terms, and a lot of people have a different mental model. And I'm looking at people around the room who are very experienced in resilient healthcare, and I'm willing to bet that I have a different mental model to some of the people in the room, and Carl will facilitate some discussion after this, and we'll see what you all think. But the first one I want to talk about is boundaries. And when I say boundaries, I'm talking about boundaries of the system in which you operate. So the idea of boundaries came from this model. It's a Cook-Rasmussen model. It's modified from Jens Rasmussen's work back in the 1980s. And it talks about a system and how a system operates. And I'm going to come and point with my finger, I think. I don't think I've got a pointer. No, you're going to get my finger pointing. Okay, so if you think of yourself as this little dot in the middle, that's you trying to do your work within an operating system. And you have different pressures that move you around in that operating space. So if we look at the back end of the operating space, so these boundaries, you've got things that stop you or try and stop you from doing something wrong or from having an adverse event. And often they're things like protocols and procedures. Sometimes they're things like regulation. But there's a whole lot of things that actually, hopefully, if they're working well, prevent you from going over that boundary into something going wrong. But then you've got all these pressures that are pushing you towards the boundary. So in healthcare today, there is an arrow. Ah, the mouse. Okay. Oh, I'm going to be a disaster with that. Okay. So usability. There's a usability issue with this. Okay. So there's different pressures that are pushing you closer and closer towards that boundary. So nowadays, we need to do more with less. So we've got this economic pressure, and there's a very high workload at the moment, particularly since and following COVID, where we've got fewer people to do the work, but we're trying to do more work. So each of those things is pushing you towards a boundary. So the next thing that's associated with that is the term of margin. So if you think about, I've got a simplified version of the diagram now. So if you think about yourself as the red dot, you've got all your regulations and protocols and procedures that are that safety pressure pushing you away from the boundary. And then you've got these economic pressures and workload. And the difference between the actual where an accident or incident happens and a safe place to operate is this margin. So, how much margin have you got between where's safe and when you go over the boundary? And one of the issues with healthcare is that you don't know where the boundary is until you've crossed it. So we want to try and maintain a safe margin because we can't see the boundary until it's too late. But we've got all these pressures. So we've got the economic pressure. Certainly in most countries, there's increasing demand for healthcare. There's the workload pressure. And certainly in my country and in many others, there's this political pressure as well to produce good care and to not have, incidents turn up in the news media of where you failed. So, and what we find is that a health system operates most efficiently right along that margin, so along the blue line, where you're doing the most that you possibly can with the resources that you've got, but you still have a safe margin. So, but the boundary's invisible. So there's signs though. There's signs that you're getting close. So if you're starting to get increasing variation in how the work's accomplished over time, if you're starting to get near misses or a lot of near miss incidents, you know that you're quite close. And sometimes staffing issues can show you. So if you're getting a lot of staff burnout, or you're getting, having trouble with staff retention, they're all these little indicators that you might actually be close to that adverse event boundary. So the next one I want to talk about is the term brittleness. So resilient healthcare comes from the field of resilience engineering. So there's a lot of engineering terms in resilience. And this term brittleness comes from the materials engineering, where you look at a material and materials respond to both stress and strain in different ways, and they can either be brittle or they can be ductile or somewhere in the middle. So what I mean by brittle is something that fails immediately. So something like glass. So if you drop a glass, it will immediately shatter. Something that's ductile is something that actually bends before it breaks. So sometimes, you have things like materials that you can bend quite a long way before the material actually fails. So these terms have moved across into resilient healthcare and are now applied to healthcare in this way. So this is a David Woods and Riethel model from 2008. So very, very early in resilient healthcare. This one's from resilience engineering, but it applies. And they've applied this idea to system behaviour. So rather than having material behaviour as you have in engineering, we've got this behaviour of systems where systems have a certain adaptive capacity as they start to be stressed. And some systems will fail in a brittle way, and other systems will be more adaptable. And the thing that actually gives you these adaptations is actually the people. So the people doing their workarounds, the people doing their adjustments every day, is the thing that makes it more ductile and gives you that more of an adaptation. So, so as an example, systems that are quite brittle, some of the high reliability organisations are very brittle. They work really, really well right up to the point where they don't work at all, and they can fail quite spectacularly. So if you look at some of the industrial accidents in the past, those are high reliability systems that are brittle. Whereas healthcare is not brittle. Healthcare is quite ductile, and a lot of that is because healthcare has a lot of people in it compared to some of these more brittle systems. So the next term that's associated with that, and I'm getting near the end of the term, so there's not a lot of them to think about, is the term graceful extensibility. And a lot of us have trouble with this because it's a mouthful to say, but two, the concept is a little interesting. What it is, it's that ductile bit, it's that adaptable bit at the top of performance. So the area that's shaded out at the moment. So as you start to adapt and you get stressed more and more and more, it's those little adaptations that allow you to sort of extend the operation beyond what you would normally extend before it fails. So probably the best example I can give of that is during COVID. So if you think about how systems behaved in COVID, rather than them just failing, they actually had all these different workarounds and different ways of doing things so that they could adapt and extend and extend and extend before they actually failed. And there's actually potential in a system like that because it extends slowly rather than fails in a brittle way. You've got an opportunity to sort of make interventions and change things as you go, because it does happen slow and you've got a bit to play with. And we can talk about that more if you have questions or want to discuss it. So how are we going for this? Have I got a little bit more time, Carl? A little bit? Okay, so I just want to talk a little bit about this safety 1 versus safety 2. So there's a lot of talk in different places about safety 2. Is safety 2 replacing safety 1? Is safety 2 better than safety 1? How does safety 2 and safety 1 relate? In short, you need both, but you need them in different circumstances. So if you think about how a healthcare system works, this is a model of an emergency department. People come in by ambulance, they're triaged, they're treated, they're either admitted to the hospital or they're discharged home. Looks like a very simple way of operating, and that's really a safety 1 of thinking about an emergency department. But what we find is that they don't really work like that. So doctors in emergency departments are interrupted in many of the tasks. They have to multitask. They spend only a very short time on each task before they have to move to another one. And when they are interrupted, they often fail to return to the task that they were interrupted in. And that's because a modern ED looks like this. So this is a causal loop diagram of an emergency department, just showing the different influences that you see within the department. And as you can see, it's a complex system. It's not a simple linear system. So often the tools and things that we would use in a linear system, when you try and apply them somewhere like this, they just don't work so well. So and that a lot of it's to do with human performance. Human performance is variable. Some people are high performers, some might be lower, but everyone's going to have good and bad days. So there's a lot of variability in there. And because you're all working in quite large teams, there's interaction amongst your teams. So if everyone on your team's having a bad day, you might end up with interactions that could lead to an adverse event or a problem. So the way we really look at it now with resilient healthcare is we like to integrate safety 1 and safety 2 and use the best tools from each depending on the situation in which you find yourself. So if we think about the space in which you operate, in terms of how complex is it and how predictable is the situation in which you find yourself, if you've got a system that's not very complex and it's quite predictable, it's really a safety 1 area. It's quite reliable, and you can use a lot of those sort of safety 1 tools that come from some of these high reliability industries. The sorts of things like management of blood products, for example, is a good example of a system that's quite linear, reliable, repeatable, and it can be managed in a safety 1 way. So in the reliable space, we can actually use that linear thinking model because you can control variables, you can generalize whatever results you find if you're putting an intervention into place. You can address problems locally and they're not going to affect other parts of your system. And you can use things like standardization, checklists, root cause analysis, failure modes effects analysis, and Six Sigma and so on. They work perfectly fine. However, often in healthcare, you're not in that system. You're in a system where it's more complex and much more unpredictable, and you need a slightly different way of thinking. So you can still use some of those tools that you would use in a linear system, but you just have to be aware that you can't control things as well. So you can't necessarily generalize results. And if you change something somewhere, it's going to affect other parts of the system. You can't just change things and think, well, it's only going to affect this part. So sorts of tools that work there are things like Lean, M&Ms, simulation's really good in that area, and some of the teamwork and crew resource management tools work quite well there as well. So that sort of general space we term protective safety, and that's just another word for safety one. So if you see protective safety or if you see safety one, it's really this way of operating in a system where it's more linear, it's less complex, and you've got better control and predictability of what's happening. So our work extends into this resilient space, and you see this in healthcare a lot, where it's just incredibly complex and really unpredictable. We saw that at the start of COVID in particularly, but you'll see that day to day all over the place. And in that sort of space, you can't use the same methods. You need to have a different way of thinking about how you deal with problems. Diversity is your friend. Understanding how work's actually done is good, and learning from what goes right, which are really safety two sorts of things. And we've got some tools which you might hear a little bit about, which you will actually hear a little bit about later today, that we can use in that space. So the other thing about the health system, which you'll be aware of, those who work in it, is it's dynamic. So it changes over time. So you can't just put something in place and then set and forget, because it's going to be a different system by the time you've implemented it. So and if you're putting in multiple interventions, they're going to interact with each other and you're going to get some unexpected outcomes. So, so the space that we look at in the resilience space, we term productive safety. It's another word for safety too. Either would be used. And the idea is that you move between the two spaces with your tools, depending on the situation that you find yourself in. So if you have a problem that's really easy to understand, it's repeatable, use a safety one tool. If you have a problem that's more complex, then you might have to start thinking about safety two or resilient tools. And in general, in terms of safety one, process-oriented things work really well. You know, so things like checklists, protocols, guidelines, things like that. In the safety two space, you really need to start thinking about goal-oriented processes. So giving your team a goal that they need to meet rather than saying, this is how you have to do it, these are the steps. And that allows people to flex and adjust and be able to do those little adjustments to get that sort of graceful extensibility bit going and be safe in that space. So I think that's probably the end or near the end of my slides. There's just a slide on linear versus complex systems thinking, but I think we're probably ready for discussion, Carl.